So I would like to start by thanking the organizers of this meeting. It has been very wonderful looking at all the presentations. And I would like to present some early work on diabetes and hypertension among older adults. We're doing some comparisons of prevalence in low to middle income countries using different forms of measurement. Before I begin, I would like to acknowledge my co-authors, which have been of great help throughout this process. So I would like to start with some background. As we all know, diabetes and hypertension are major causes of morbidity and mortality globally. But in low to middle income countries, these diseases are of particular problem. They've been increasing, and they affect a large proportion of the population. And a lot of the main question we had when we started working on this was how prevalent are these conditions in low to middle income countries? And when I started doing my literature review, we realized that, well, actually, the prevalence of the disease has a large range, and it varies quite a bit throughout hypertension and diabetes in all these countries, which are, by the way, the 4 countries I'll be looking at on my slides, on this research, and you'll see on the slides. And the reason that there's such large ranges here is because they vary depending on the measurement that's been used to capture the disease. So for example, a lot of the research that has been done using population data. A huge pro of population data is that it is representative of the population. And some issues that it has is that, if you're really thinking about these diseases, you depend on the respondent to know and to be aware that they have the disease. So they need health literacy, or you depend on them to be engaged on the healthcare system. And in low to middle income countries, these can all be issues. The other option, or the other studies that sometimes occur, are clinical studies. And the pro of the clinical study is that these measures are very accurate. They usually happen in a clinic, in a hospital, so you know exactly what that the measures are good. But the cons is that they're expensive to do, and they're usually, or not always, not representative of the population. But now we have really well done population studies in several low to middle income countries where the respondent says what the diagnosis of their diseases are. And additionally, samples of blood and anthropometric samples are collected. And we can leverage the strength of each to overcome the weakness and see what is the most reflecting reality. This means that we could look at both sides of these pros and cons I'm showing you and identify if maybe there is a better measure or different measures we could use to understand prevalence. So overall, what we want to do here is to calculate the prevalence of hypertension and diabetes using reported data. So the person says they have this disease. Looking only at measurements, so if only anthropometric measurements or blood measurements, and then we want to look at the combination of the two and compare them throughout these countries. So these are the 4 countries I'm using in this research. It's China, India, Mexico, and Colombia. Just so you are aware, we're only taking into account ages 60 plus in all of this analysis that you'll see. And I'm not going to spend too much time talking about these studies because we'll only have 12 minutes, but I'm assuming most people here are aware or know about these studies. But there's 2 main points you should know about these. These 4 studies are nationally representative of older adults, and they all collected information on reported diagnosis, on biomarkers, and on anthropometric measures. Okay, so what is the source of measurement? We looked at a reported diagnosis, so each respondent in the surveys had to say if they have been told by a doctor or a nurse if they have diabetes or hypertension. We also looked at blood pressure. So what we did here was for China and India, we took the average of the second and third reading of blood pressure. For Mexico, there's only 2 readings. We took into account the second reading. If the person didn't have a second reading, we took into account the first reading. And for Colombia, we took the average of the second through the 6th reading of blood pressure. The reason why we tried to never include the first measure was because we were trying to avoid a white coat effect. And for diabetes, we used glucose that we used for China and for Colombia. The venous blood was what was taken, and we measured glucose using those measures. Mexico used a finger prick, and using a glucose meter, they captured HbA1c, so that's what we looked at. And unfortunately, for now, we don't have the India data, but hopefully we will, and we can include it in our analysis as well. So this is just to give an overall idea of how the measurements work. So basically what we're looking at is if the respondent reported yes on having told by a doctor that they have diabetes. We looked at clinical cut points for measured data. So of course, depending on what the blood was taken or how the blood was taken, the measurements varied a little bit. But what we're looking at is clinical cut points. Do they have diabetes? And then finally, we looked at a combined measurement, which means what we're trying to see is gather both of information. So did they measure high or did they report that they had this disease? Oops, sorry. Okay, we did exactly the same for hypertension, of course, using hypertension clinical cut points. And now I'm going to show you some results. So this is the prevalence of hypertension by measure by age category. Your y-axis is the prevalence, and in the x-axis, you'll see the age groups, and they range from 60 to 64 all the way to 85 plus. And these yellow lines represent the reported prevalence of hypertension. So this would be what we would capture if we would only look at the self-reported disease. If I include the measured disease, then we can start to see some differences. So for example, in Colombia, the self-reports are much higher across all age groups than the measured. In Mexico and India, they're similar. And in China, at older ages, we see that they separate, and measured hypertension is higher than reported. And if we look at these two measures combined, we can see that the prevalence is the highest when we have the combined measures, and it is a really good indicator that this might be the best indicator to capture the prevalence of the disease, because it is accounting for both possibilities. Let's walk through some of these results. So, when we were discussing what these graphs mean and what these results can tell us, what we thought, and then we went back to the literature to check, is it looks like in India and Mexico, there's a low awareness of disease. And actually, a lot of studies in both countries have highlighted that although people know, that people don't know that they have the disease, and that even though amongst those that do know that they have the disease, they're not receiving any treatment to control it. And in Mexico, these were the same results. So here I have a ton of references for India and for Mexico separately. When we looked at China, we realized that, okay, so these results, what they're showing us is that there's low awareness of disease, and this is particular at older ages, and actually other studies have reported the same. And in Colombia, it's kind of the opposite story, which is there's a high awareness of disease, and here what you can see is most people reported that they had hypertension. Because of time, I can't separate the slides for diabetes, but here you get the same idea. So what we have here is Colombia is in this panel, and you can see that the reported measurements are very similar to the combined measurements. The measured measurements are the lowest, and in China and in Mexico, this is quite a sort of the opposite story. So what we can what our results compared to the literature, what they show is that there is low disease awareness, and it is particularly stark, at least from what we can observe here in China, among the oldest old. In Mexico, I would just like to highlight that it seems that at the younger ages, there is higher awareness of diabetes, and as ages progress, the awareness gets lower, but it is still a really important thing to keep in mind, because the oldest old adults may have more difficulty accessing healthcare. And for Colombia, there seems to be really high awareness of disease and controlled diabetes, which is really promising. So some of the main conclusions we can do here overall is that what we can see is there's low awareness of disease in low to middle income countries, and there is uncontrolled disease. But one of the things I really wanted to point out is that how we measure the prevalence of these diseases will vary significantly. So for example, here I have the prevalence of hypertension only with reported. So if we only looked at the self-reported, this is how the countries would range from the highest prevalence of the disease to the lowest. But if we looked only at the measured data, the story would be different. The ranges of the prevalence vary. And then if we have a combined measurement of both of them, it still is different. And so we thought this was really interesting. This happens both in hypertension and with diabetes. And oh my gosh, I have 1 minute. Okay. And for sort of the conclusions we want to make here is that, when we're thinking about how these diseases are captured and how cross-national comparisons happen, we need to keep into account that how these information is received can vary, but not only that, one of the big discussions we had in our lab when I was presenting this work was, well, did the collection of the blood vary? What variations could that mean for the results? And then also, how was the anthropometric measure? So we were discussing about the number of measures that Colombia took versus Mexico, and what does this mean for cross-national comparisons? However, the big takeaway is that it seems that the combined measurement of both reported and measured information can be a gold standard for future research, since it captures a really the true prevalence of the disease. Thank you.